I'd like to welcome you to our afternoon session, and it's bound to be as great as the ones early on, and we're going to be talking about an incredibly important topic. Before I introduce our speakers, I'd like to say that I started working for a Medicaid program not in 1965 when I was 2, but in 1974 when I was about 8. You can do the math. And I negotiated some contracts at that time in New York State between the 3 HMOs in the state. We'd just gotten the language the year before. And Medicaid. Who would believe the difference? Who would have predicted that on our 50th or 50th and a half anniversary today, Medicaid would be the largest health insurance program in the United States? Growing, achieving significance, continuing to change, continuing with innovations, with lots of potential and lots of problems. We're going to hear about all of that today from multiple perspectives as we focus on California and the nation. To lead us off today is Howard Kahn, who's the former CEO of LA Care. And as you know, it's the nation's largest publicly operated health plan, which has more than 1.6 million enrolled members in LA County. He is widely recognized as an expert in governmental health care programs, health disparities, and our safety net. And he's also had 25 years of experience in national and international health care at Cigna and also at Aetna. Where haven't you been, my man, Howard? With no further ado, I'm sure you'd rather hear from him than hear from me. Howard Kahn.
So I'm not Jennifer Kent. I'm not the director of the Department of Healthcare Services. And given her job right now, I'd rather be a 59-year-old bald guy with a titanium hip, which I am. It's a better job. I'm standing in for Jennifer today because she's been called away to budget issues that she needs to address in the Capitol. And so I am happy to be here. And as a neighbor from LA County, I'm glad to come down south of the curtain, which I do on occasion, and it's turning out to be a really nice day. So very glad to be here. I'm not going to talk directly about the Medi-Cal budget as Jennifer was going to do, because you should never talk about stuff that you don't know very much about. And I'm not in the middle of that budget fight right now. I should say discussion. Fight comes in a couple of months, but I'm not in that budget discussion right now. So instead, I'm going to try to frame our discussion today a little bit larger in terms of Medi-Cal. And whenever I start to think about Medi-Cal, and I think about where, as Deborah just said, where we've come from the 1960s to now in the Medicaid program, I always think to myself, and then there's Medi-Cal. And then there's Medi-Cal, because Medi-Cal is really an animal unto itself. Each state has its own program, and none has been tinkered with more or has had, in some respects, a greater impact and been a greater burden than our Medi-Cal program. Right now, 1/3 of Californians are on Medi-Cal. 1/3 of Californians now, after Obamacare, are on Medi-Cal. It can't be the one-off that it once was. Medi-Cal used to be an afterthought in a lot of people's minds, but now with 1/3 of the population there, we can't really think of it that way anymore. We've had some big victories in California over the last few years. Obamacare covered California, Medicaid expansion, more recently, the extension of eligibility to undocumented kids. The new waiver that was approved that was kind of a plus and minus in terms of the results. And then it looks like a settlement on the health plan fee tax term of the month. So we've had some real positive things happen over the past few years here, but we still essentially have a Medi-Cal program. And so this is my context to give some background for the presentations that will be at a deeper level that you hear later. And the question that I want you to ponder as I'm talking right now is, are we treading water within the Medi-Cal program, or are we moving forward? Because we've really treaded water in a lot of respects. Although we've expanded eligibility massively, we've spent a lot of time treading water over the last number of years, I think. And now there are a lot of changes going on, and I'd like you just to think about whether or not we're moving forward in a direction or just at a bit of a standstill. So let's talk about what Medi-Cal was historically, because in reality, I think that Medi-Cal, although very important from an eligibility standpoint, it was really the federal government, the state government, the counties, the hospitals, and labor having discussions about what the program ought to look like, with some input from the physician community, with some input from the legislature, with some input from the community clinics. But that's really how this program has been managed and driven over the last many years. And I'm not sure that formula works anymore going forward. With a third of the population, again, in Medi-Cal now, we have to think, I think, about it differently. And over time, the counties have actually provided more and more funding for the Medi-Cal program. The state's general fund has not been, it's been declining significantly. I think from the overall Medi-Cal state's contribution, I think it went from 90-something% down to the mid-60s over the last 8-9 years. And we're also in a time where we're going to see decreasing federal supplemental payments, which have really propped up and supported the Medi-Cal program. And the state's in a really unique position because not only does it have a third of the population that it manages through the Medi-Cal program, but you add on to that, the state has the PERS program and the other public employee health benefit programs. The UCs are the largest employer in the state of California. Covered California itself, another creation of the state. The state potentially has an awful lot of leverage over how we provide care through the Medi-Cal program in the future because it's so substantial in size. And so what I'm trying to say is that I think we need to start thinking about the Medi-Cal program significantly differently than we have in the past. So a few paradoxes for a moment, unique aspects to California. We talk about California as if it's one place. I think all of you know the California markets are dramatically divided. And very different from one another. The LA doesn't look like the Bay Area. It doesn't look that much like Orange County. Certainly doesn't look like San Diego, or a lot of the valley areas or some of the rural areas. These are very, very different markets, all operating under one hodgepodge of Medi-Cal programs, and I'll talk about the hodgepodge in a moment. In some of the markets, we have real provider dominance. Sometimes hospitals, sometimes physician groups, even in some of the areas. In other markets, it's kind of the Wild West. I come from having run LA Care for 13 years, a Medi-Cal program in Los Angeles County, and there are aspects of the medical care delivery system in LA that are just really the Wild West, with vastly different levels of quality of the delivery system and access throughout different parts of the county. But never in the power dynamic that we talk about with Medi-Cal have we really seen the consumer enter in directly into that discussion, the Medi-Cal beneficiary directly or even by real proxy very often into that discussion, except that everyone has supported, or a majority have supported, extending enrollment, which has been a very positive. Coverage is a very positive thing, but in and of itself is not enough. You know, California, I said, you know, Medi-Cal's different. California is still the cheapest Medicaid program. I think that's still true, isn't it? Still the cheapest Medicaid program in the United States, operating in one of the most expensive markets in the United States. Yet in Medicare, we're way up there. Commercial, sort of fair to middling, depending on how you view it, fairly efficient. And then the dual eligibles, the folks eligible for Medicare and Medi-Cal together, are extremely expensive in some of our markets. So it's very hard to talk about California in any unified sense. And then we have the public plans and the county organized health systems, as you have here in Orange County, the two-plan model counties, the geographic managed care counties, and now a few just sort of miscellaneous out there. But we're the only state in the country that have these public plans. It's a unique structure that we have for the largest Medicaid system in the country. The majority, I think it's something on the order of 70%, last I checked, of the Medi-Cal recipients are in public managed care plans. So that's very different than any place else in the United States. So Medi-Cal really is Medicaid in a California version that has remained and has developed very differently over time. The quality ratings have always shown that the county organized health systems do the best of any of the other Medi-Cal forms in California. So logic would have it that you should just say, well, let's just make all the counties county organized health systems. Ain't gonna happen. It's not going to happen because there's way too much invested in the other models, because not every county has the capability to do that the way counties like Orange, San Mateo, Santa Barbara, and some of the North Bay counties have done it. But it's a model, those are models that are worth continuing to examine as we go forward, especially considering 70% of the managed care Medi-Cal membership is already in them, to say how do we make sure that we retain the strengths from those systems. In a lot of parts of the state, the Medi-Cal system, because it's so cheap, is held together by the safety net, by public hospitals, by community clinics, by public clinics, by some not-for-profit and for-profit safety net hospitals. Those, in those places where that network is being held together, those providers are being supported by one form of supplemental payment or another. That is, the payments that Medi-Cal makes straight up just don't support that safety net to continue to operate. So as those supplemental payments start to get shrunk down by the federal government, the question is going to become, what do we do with the safety net? How do we either support the safety net, convert the safety net, et cetera? And that's part of what I think is going to be talked about in terms of the waivers that are going on now. You know, it's hard to overemphasize the power of the monetary investment. The stakes are so high in the Medi-Cal program from the state's perspective, from businesses' perspective, and from the safety net's perspective. So in thinking about where the program is going over the next few years, I think we have to consider what's going to happen to the safety net in that process. There's been massive growth in community clinics throughout the state as a result of Medicaid expansion. There has been some level of shrinkage at the county hospitals already in those counties that have county hospitals as a result of Medicaid expansion. And we've seen some first inklings of that. Again, the safety net is held together with these supplemental payments, and that process and the waiver process is going to continue to evolve almost too soft of a word. It's going to quickly change over the next few years, most likely. And there are no here. I'm painting sort of a negative picture, but let me just say that there are no heroes and no villains in all this. There are folks who have just been trying to survive as providers, as consumers, as new eligibles. And let me spend a moment on new eligibles. The voice of the consumer has rarely been heard. The voice of the beneficiary has rarely been heard directly in the Medi-Cal program. All the providers have been heard, and many times providers come forward as the voice of the consumer. But we've rarely heard from the consumer directly. So here's the change that's come about as a result of Obamacare. We now have people enrolling in the Medi-Cal program who are either the children of the middle class or the future middle class. That is, we've taken in folks who are simply not earning enough. Very often, those folks are accustomed to having much more voice in the way things move forward. And so I think what we'll be seeing is perhaps a change in the voice that we're hearing in the Medi-Cal program as a result of that. In a sense, it's becoming more mainstreamed as a result of Obamacare, which I think was an unintended consequence and probably a positive one. But we've ignored some of the critical issues. So I've got a couple of last points I want to make before I sort of wrap up. One is that we've ignored issues conveniently because it's worked, because we've had to make this system work. So a key example of that. There's a state law, regulation, that says that you can only have 2,000 members per primary care physician in a practice. That's the maximum size of a practice. And so if somebody is getting certified as a health plan, they show their access and they say, well, there's this number of physicians and we have this amount of access possible because it's 2,000 patients per physician. But what nobody does is go and sum up how many times that physician is signed up with another health plan. So you can have somebody that's got 2,000 patients 5 times. And that's not even counting the commercial side. I'm just talking about the Medi-Cal side or the Medicare side. But there's no point along the process where anybody says, wait, does that doctor have 15,000 patients? 10,000 patients, potentially? So there are things, and everybody has, to be honest, known this for a long time. But to make the system continue to work, we've made those kinds of choices. So that sounds cynical, that sounds negative. We have a lot of challenges in the Medi-Cal program, but I'm going to wrap up with some of the current trends and to just say as well, you could be cynical and say everybody's been playing a game to keep the money flowing, to keep the system barely operating, or you could say that folks in California for a long time have been almost heroic at piecing together a system that's had to live under Prop 13 and all kinds of other budgetary restrictions and end up in a place like we are now where we have actually a pretty creative mix of programs that perhaps can be slowly evolved into something that starts to really reflect the quality that we've been talking about and that's implied and hoped for in some of the healthcare reform that we've seen lately. So a couple of things about the trends, and then I'm going to wrap up. Providers and health plans have woken up to a very big market, the Medi-Cal market. Somewhat late, but they've now woken up to the fact that there's a big market out there. As I mentioned, Medi-Cal is now being populated by the past and future middle class. And I think that will change and make louder the voice of the Medi-Cal beneficiary. We've seen that in long-term care for a long time, but it's been a little secret that it's populated by the middle class. We're seeing significant consolidation in the marketplace right now. We've yet to see whether or not that actually adds value in any significant way, but we're seeing considerable consolidation. These are big trends that are national, but in particular, we've been seeing it start to really carry over in California. We have 18% of the economy, nearly 18% of the economy tied up. Everybody is putting another layer into the healthcare system right now because they're attracted to the money that's in the healthcare system. So we keep getting layers and layers and layers added onto our system. Again, the value add question, I think, is still out there. And yet on the positive side, we're seeing the first steps that we've ever really taken, big steps toward measuring quality, towards measuring value, towards trying to say, let's get away from just paying for care based on how much it's cost before and to start to look at some of the value adds. And so I think that our movements that we're seeing right now are as positive as you could hope for given the situation that we're in, but I think the question comes back to whether or not creeping incrementalism, as we've done it thus far, is going to work, or whether or not we have to have a larger change, whether that creeping incrementalism is essentially our Achilles in this process. And I think over the next few years, probably over the next very few years, we'll find out whether or not we're really moving forward, whether we're making real progress or not. And then now I'm going to get out of the way and let folks who have depth of knowledge in very specific areas talk a little bit more about it. Sorry for the lack of a budget update. Thanks a lot. Devin?